Hello, this is a lecture on clinical toxicology. Here we will be discussing about the basic principles of management of a patient who has been poisoned, and we will also go into a little bit deeper understanding about the common agrochemical agents and pharmaceutical agents that results in toxicity, especially in Sri Lanka. So, as I said before, I reiterate, we will be talking about the general principles of management of poisoning. And it is essential that general principles of managing a patient who's poisoned are applicable to specific principles of each of the toxins and the poisons. So, we will be talking about the general principles of managing somebody with poisonous exposure, and it's applicable to the specific principles of each and every item that you may come across. And it is essential that one uses common sense and clinical reasoning. I hope you understand what clinical reasoning is using the mind, using the brains in determining what is common and what is uncommon and what is underlying and doing good for the patient without harming the patient. There are two important principles in toxicology. The first principle is that when you are managing a poisonous exposure, a toxic exposure, do not forget that the patient has already been poisoned. The second principle is that you ought to treat the patient and not the poison. So, firstly, you have to understand that the patient has been poisoned and there is harm happening and there is harm that has happened. And you need to reduce the harm that will happen in the future. The second principle states that you need to treat the patient in a holistic way, body, mind and spirit, and not the poison, not the substance that is there on the label of the carton or the bottle. And very important that you do not be judgmental. You are not to judge the patient if the patient has intended to commit suicide or intended to harm somebody or whatever circumstance. You should not be judgmental and do not act in a callous or cussed way. Callous as in very, very obnoxious, very rough way, where the patient can be put into rudeness and the patient can be put into a difficult situation in front of many others and with the infringement of the privacy. So you have to act non-judgmental and you have to act with kindness and empathy. So there's a thing called this chain of survival, where you need to look into this, where you need to consider this, because that will reduce the harm. As I told you, harm has already been done and there is harm occurring. So just like the way that you treat a patient coming with ischemic stroke, and you treat quickly to reduce the ischemic penumbra, the harm that goes on as ripple effects, you need to do the chain of survival to reduce the harm from the poison. Firstly, you ought to decontaminate the patient at that particular spot. Removal of clothes and washing the patient, right, and taking the patient away from that place. So that is called spot decontamination to limit the internal contamination. Nextly, you need to identify various constellations or various groups of signs and symptoms that they come. Those are called toxidromes, which we will talk about. The third thing is you need to administer the antidote, the pharmaceutical agent that will counteract, antagonize the effect of the poison. Then you need to do extensive decontamination to further protect care system. So you need to further remove the poison that is in the substance of the patient. We'll talk about that. And you need to transport the patient to the hospital to complete the cure. So, as I told you, there are some things called toxidromes, which is a portmanteau or a neologism. It's a mixture of two words, toxins as well as it's a syndrome. So, there are syndromic appearances of toxin. So, this is what we describe. We will come to that as we go on. You go in an algorithmic way and you try to fit in if you do not know what the patient has ingested or patient has been poisoned. You look at the pupils, you look at the temperature, you look at the bowel sounds, and you come to this. We will talk about enough. So the principles of management in toxicology includes maintenance of airway, breathing, and circulation. ABC, as in any kind of emergency situation, and this is the order of critical deterioration of any patient. If the airway is compromised, that will be the first thing to cause the patient to deteriorate and even lead to death. Then it's breathing, and then it's a circulation. So you need to maintain, you need to support airway, you need to support breathing and support circulation, as in all kinds of emergencies. So you start off with that. So then you need to get intravenous access in adults as well as in older children. In infants, you may use intraosseous lines. You can also use per oral administration of fluids to correct the fluid status and electrolytes. Remember, dehydration can settle in, as well as alteration of electrolytes in the poisons. So you need to work on the fluid status and the electrolytes. This ensures satisfactory urine output, which is the indicator that the kidneys are working and the kidneys are not shut down. As in all emergencies, you need to check on the sugar levels, the random blood sugar, because again, metabolism can be affected in any emergency, and you need to correct the sugars if they are low or if they are even high. So link up your endocrinology with that. Arterial blood gas may be needed when necessary, especially if there is compromisation of the respiratory functions, or if there is metabolic acidosis, which you will learn in the renal module. And you'll need to look at renal and liver functions. You may, at certain points, certain poisons, you may need to do poison levels, like let's say paracetamol or even urine toxicology, but they are not widely available in all situations and in all stations. You need to anticipate and treat anaphylaxis, because poisons are extraneous substances, they are external substances, so they can generate a type 1 hypersensitivity reaction and mount a state of anaphylaxis. So you need to anticipate and treat anaphylaxis. In the same way, convulsions too can settle in, because poisons can give rise to alteration of electrolyte levels. Poisons can also bring down the seizure threshold. If you can remember, seizures come because there is abnormal electrical activities happening in the cerebral material. So poisons can affect the electric activity of the brain and reduce the seizure threshold, or generate seizures and cause convulsions. So patients who are also critically ill or poisoned, they may need cardiorespiratory and other organ support, so they will need level 2 care, where you may need to put them to the intensive care unit or a high dependency unit. So you ought to remember that patient stabilization should take precedence over decontamination. You have to always stabilize the patient, because no point in washing the patient or getting the patient's stomach contents out. If you are losing the airway and the breathing and the circulation, by that time patient would have succumbed, and then all your effort will be in vain. But remember, decontamination should occur simultaneously to stabilization. It should happen together, and it should not be certainly delayed. So, gastric decontamination. What do we mean by gastric decontamination? This is actually removal of the poisons from the stomach. So, this should be done for those who are able to protect their airways, those who are able to talk with good power of voice, who are able to cough, gag, and patients who are able to swallow without having aspiration, or if they without having choking. So those are those who are able to protect the airways. If not, they need to have a protected airway in the form of an intubated airway, or might have to put alternative means of protecting the airway, like a LMA, laryngeal mask airway. Right. So most of these people will benefit if the ingestion has happened within 1 hour. Like the patient has come within 1 hour of ingestion, you can decontaminate the patient. But even so, if patients have taken large quantities of medication, large supratherapeutic dose medication, or if they have taken control release medication, where medication released in the GI system at a slower rate, extended release, control release, so they would benefit from gastric decontamination. Or also in those who have consumed oleander seeds. We'll talk about that in plant poisoning lecture. So remember, you do not induce emesis, you do not induce vomiting. In the olden days, people used to induce vomiting by giving sodium bicarbonate or the syrup of ipecacuanha. That is, it's a emetic agent. It induces emetic. In our own shows, what do people used to do? They used to give polkiri, coconut milk, to induce vomiting. It should not be done. It should not be encouraged. It should not. And it's neither beneficial in hospital, because they will cause more harm, because patients can aspirate, patient can breathe in the gastric contents while vomiting and cause aspiration pneumonia. Poisoning. Another means of gastric decontamination is by doing a thing called the gastric lavage. It's not routinely done, but it can be done, especially in children who may not be cooperative in taking this activated charcoal or any other absorbing agent. So it's not routinely done, but it can be done when a doctor is in place. What you do is you send in water or normal saline through a NG tube, a Ryle tube or a NG tube, and you do that like a cyclic way up to 3 cycles. See how the child is positioned. That's how you do. The reasons are that gravity sets in and the shape of the stomach. So that's how you do, and you suck out the gastric contents after letting the fluid circulate within the stomach. Nice to know things are elimination by giving multiple dose activated charcoal, and there is alkaline as well as So remember, poisons are there in many things, in serpents, in insects, in scorpions, but the malevolence which emanates from the entire corpus, entire body of the wicked is the worst out of the lot. Thank you.